Good morning. Welcome, everybody. Thank you for coming to Primary Children's Pediatric Grand Rounds. I'm Miguel Canacle, your course director and one of your pediatric hospitalists. Thank you to Jeff and Ethan, the AV behind the glass, and Julie Hanks, an educator who's our Pediatric Grand Rounds coordinator. Today's credit code is 52518 for everybody to claim. And the online questions go in the live chat. And in the auditorium, you just raise your hand and the speaker calls on you for the questions at the end. Please nominate a safety hero for a Safety Hero Award. So when you see someone using error prevention technique, this one, we've had a lot of nominations about nurse educators. They are in these simulations. They're always looking in the crash carts. They see the discrepancy. So this is one about stop and resolve. So during a simulation, a nurse educator found the epi in the anaphylaxis kit was labeled adrenaline, but the sims and the training and everything has always said epinephrine. But since 2018, we've had adrenaline in the crash carts, but not for the training and the sims. So that the education, the teaching also shows the 1 to 1,000 and the 1 to 10,000, the dilutions of epi, but and on the drug cards also show the dilutions, but that was changed by the FDA. It's supposed to be milligrams per milliliter. So everything, this nurse educator found that and worked with all the teams, and it was many different facilities at Intermountain, fixed it all and made it all coordinated, because you don't want to be not knowing what you're reaching for in that situation. So appreciate the stop and resolve from nurse educators. This is the registration for Pediatric Health Equity Symposium on February 6th. Still time to submit an abstract as well, and I'll put the links in the chat also. And now Dr. Vijay Ravindra of Pediatric Neurosurgery will introduce our speaker.
Great. Good morning, everybody. It's my distinct pleasure to introduce our Grand Round speaker for today. Some of you know her well, and many of you have spoken to her in the middle of the night, probably when a patient, or you, in my case, really needed some help, likely at 3 a.m. So Dr. Lisa Pabst, who's a pediatric stroke neurologist who did her undergraduate medical school training in the great state of Texas, completed her pediatric neurology training and stroke fellowship at Nationwide Children's Hospital in Columbus at The Ohio State University. She's a Texan by school and trade, but a Buckeye at heart. She's deeply involved in pediatric stroke care through the region and has helped pioneer a pediatric telestroke program so that kids in trouble can really get urgent pediatric neurological evaluation. A lot of kids and families have benefited from the decisions that she's made in the middle of the night. A lot of providers have benefited from having someone calm, decisive, and very, very oddly awake on the other end of the phone. She's a gifted clinician and an exemplary academic. Here at Primary Children, she's brought several national and international clinical trials, including Save Child's Pro and the FOCUS trial, and several registry studies to really bolster our national reputation and give our patients access to these trials. She's leading our Kids Interdisciplinary Neurovascular Disease Clinic, which just received Primary Children's Hospital Foundation funding. When you see her on the wards, she's all about organization and protocols and efficiency. If there's a faster way to get something done, she's going to find it. If there's a checklist, she wrote it and she's going to make you use it. And when someone is so organized and acts so swiftly, you would assume it extends to every aspect of her life. It most certainly does not, specifically cooking. She can coordinate stroke care across multiple regions and states, but her family is firmly of the belief that appliances that have an on-off switch are probably the best bet at something edible. And apparently there's an air fryer that entered the picture recently, so stay tuned or just get Uber Eats ready on your phone. Lisa is known for many things, but her outfits are probably what I think she's most famous for. She has the most flashy blazer collection at Primary Children's. And among our neurovascular team, she's known as the Madam Prime Minister, most recently upgraded to Madam President, though we're not sure what country she's governing at this point. She's definitely our boss, and we would not survive without her leadership and enthusiasm. Outside of pediatric blood vessels, she's a great and passionate skier. She skis intensely, competitively, and with a strong belief that everybody needs to move faster, much like how she thinks about our stroke patients. She brings a certain level of intensity, you'd call it. Some say it's focus, some say it's drive. But when a child is having a stroke, the level of commitment that she shows is exactly what you want on the other end of the line. And she's pretty well dressed, so that doesn't hurt either. On a personal note, I started here 6 months ago, and I witnessed her managing, along with the rest of the multidisciplinary team, 2 really sick kids with vein of Galen malformations, which are kids that have multi-system organ dysfunction secondary to a large malformation in their brain. These kids were on the brink of death. We saw 2 of them this past Tuesday in our clinic, and they are thriving. Lisa and her leadership has given them a chance at life, and that's not a joke. With all the joking aside, she's had a real impact on how stroke care has been delivered, and she's supported families, patients, and our colleagues in some of the most stressful and tense moments. You look up and she's in the operating room, she's in the angiography suite, she's got boots on the ground, and she's the support that you didn't know that you needed. And so I want to welcome Lisa to give a great talk today. She's our Commander-in-Chief of Blazers, our telestroke builder, my colleague and friend, Lisa.
Thank you. Thank you, VJ, for that introduction. Unfortunately, I chose a sleeveless blazer today, but I think still on brand. So we're going to talk about some of the exciting changes in how we care acutely for children with stroke. I have a disclosure not related to today's presentation. These objectives were published in the announcement email. To give you a roadmap, we're going to talk a little bit about my history, the history of the field of pediatric stroke, and spend the bulk of our time talking about strategies for caring with children with stroke. I put these small blue boxes shown here on the top as just to highlight some key terms that are not, there's no quiz at the end, you don't have to memorize them, but I hope can kind of serve as a shared vocabulary. So I grew up in Crosby, Texas, shown here by that house, surrounded by grass farms. This is Murph's Turf Farm, which supplies millions of square feet of sod or grass across the region every year. And the irony is not lost on me that now I live in Utah, where my lawn and I are both just trying to do our best every year, and a grass farm sounds like a foreign concept. But going from that kind of rural area, I then went to medical school in Houston and was surrounded by, the world-renowned cutting-edge medical care provided in the Texas Medical Center. And it was really striking me to see the difference in what I saw was possible with this high-level care versus the care that I saw many people from my hometown actually access. I then went to Columbus, as VJ mentioned, and spent 6 great years there. This is German Village, a great neighborhood. This is the Book Loft, which has 32 crammed rooms of books. And really tests your sincerity on when you claim you like to read. Became a big Ohio State Buckeyes football fan. This year, frankly, is a little bit more of a humbling and character-building hobby, but we do get to say we're the reigning national champs for one more day. But most importantly, I got really good training at Nationwide Children's and got the opportunity to train in stroke between there and the Ohio State University. I spent a number of months doing adult stroke as part of that training, and I did psych myself up every day driving there saying, I'm doing this for the kids, I'm doing this for the kids. But that training was really important. And one of the greatest things about that was seeing how adults were using telestroke to rapidly connect an adult stroke neurologist to an adult in a rural place to help make the most high stakes, high rewards decisions, when every minute mattered for that adult having a stroke. And I wanted to do the same thing with kids. I also wanted to live somewhere where I could go skiing. Enter Utah. In many places, the idea of doing telestroke for kids seemed aspirational. But here, thanks to the work of many people in our department, many people within children's health, our institution was already on the cutting edge of using innovative, acute telehealth for kids. And so my vision of being a skiing pediatric teleneurologist was born. But enough about me. I think to kind of know where we are right now in stroke care, it's interesting to look at the past. Some people think the first mention of stroke in childhood actually dates back to Shakespeare and Richard III. It turns out he didn't have that flexed arm and use a cane at a young age because of childhood stroke. It's actually terrible scoliosis that was determined. But then later in the 1800s, we started to realize that some children with cerebral palsy had more of a hemiplegic phenotype, and turns out that was from perinatal stroke. And then in the 1930s, you get a large autopsy study confirming that babies can have stroke around the time of birth. The 1950s, you get the first report of a large vessel occlusion in a child with a carotid thrombosis who unfortunately died 3 days into his course, highlighting how devastating stroke is when we don't know too much about how to care for it. The 1960s, we get the first report out of Japan of a disease with the spontaneous occlusion of the circle of Willis. Anybody know that disease? Moya moya. And then in the 1970s and 80s, you get increasing literature really highlighting that stroke in kids is not just a one-off case report phenomenon. It's rare, but it's a consistent recurring entity. And so then in the 1990s, the field of pediatric stroke really started to emerge and become organized. Around that same time, adult stroke already had big trials, and they had their first big breakthrough, which was the FDA approval of TPA, or clot-busting medication, to treat adults with stroke. 2003 is when the International Pediatric Stroke Study was formed, which was a pivotal moment, forming a foundation for global collaboration and systematic study of children with strokes. 2010 to 2013, we get the TIPS trial, which was an acute care trial for kids, trying to give them TPA, and we'll talk about that later. And ultimately didn't enroll enough patients. Over the subsequent years, multiple adult studies continue to rapidly change, the effective care of adults with strokes with the use of thrombectomy. Interestingly, it was actually 2014 when I attended my first Child Neurology Society meeting in Columbus, didn't live there yet. And that year they happened to have a pediatric stroke symposium, and that really got me hooked on pediatric stroke at the time. But the discussion was largely around the cause of stroke in kids and how they do in the long run, and the fact that they're pretty resilient. It wasn't a whole lot about treatment. But fast forward to just the last couple of years, and we now have multiple ongoing clinical trials for how to better care for kids with strokes. And so I feel like we've really reached an inflection point in how we're going to change these children's lives and give them the best lives possible. So to get into it, I thought I'd tell you about the very first patient I took care of after I came here to Utah. This was a 5-year-old boy. He was in his normal state of health, dropped off at kindergarten at 8 a.m. At 8:30, he's sitting in a reading circle, and his teacher notices he's leaning over and he won't talk to her. She calls the nurse, who thought maybe he had a seizure, and calls the mom and recommends the mom pick him up and take him home. Mom notices he has a facial droop and said, could he be having a stroke? And she's told, no, I don't think kids have strokes. Just take him home, call your pediatrician. Mom was nervous and didn't like that answer, so she took him to urgent care. And they watched him and they said, yeah, he probably had a seizure. Let's just keep an eye on him. He wasn't getting better. They got a head CT. That was normal. And they said, see, it's not a stroke. Still not getting better, so he gets transferred to his local emergency room with pediatric support, and he's still not back to baseline. They continue to monitor him, thinking he must be postictal. Eventually, he's not getting better, so they admit him to the pediatric hospitalist team overnight for observation. The hospitalist goes to evaluate him and is immediately worried that this child is having a stroke, given a striking right-sided weakness and aphasia. Gets a rapid MRI, shown here on the top right. This is a diffusion-weighted image sequence. And this shows stroke within minutes of it happening, as opposed to that head CT, which can take hours or days to even show a stroke when it happens. They also got a MR angiogram showing his vessels, and what we see is severe narrowing of the middle cerebral artery and potentially a cutoff in the middle of that. Unfortunately, this is a common story. So stroke is rare, but it happens in up to 10 per 100,000 children per year in the US. And we definitely have the higher end of that, incidence range here in the Mountain West. And delayed diagnosis is one of the biggest problems we continue to face. People don't know kids have strokes. They don't look as striking. They don't look as severe. Studies have shown that 2/3 of kids present to the hospital within 3 hours of onset, and yet the average time to diagnosis is almost 24 hours. And why does that matter? It's because every minute matters when we're dealing with a stroke and a lack of blood flow to a part of the brain. Children often have a vasculopathy or a problem in their actual blood vessels, where simple things like giving them aspirin, giving them IV fluids can help maintain blood flow through a narrowed artery. We have therapies available to restore blood flow in certain cases. And one of the important things to understand is that stroke mimics are more common than actual strokes in kids. And so up to 70% of kids with symptoms are really experiencing something else, though much of the time it is a neurologic emergency. So these are the common ways that kids present with strokes: weakness on one side of the body, changes in their speech, slurred speech, difficulty getting their words out, changes in vision, changes in balance. Headaches can be quite common. Altered mental status, which always makes it a challenge because that has a whole wide differential in and of itself. Seizures, especially in our infants and toddlers. Seizures are the herald sign of stroke in up to a quarter of them when they're presenting with stroke. A lot of people use the acronym BFASTs: balance, eyes, face, arm, speech, time is of the essence, and seizures. Those are our symptoms. Another important thing about kids is they often, it's not an all at once really striking phenomenon. They're a little more resilient than adults in a lot of ways. And so often it's, they're a little weak in their arm, or their face is a little droopy, or their speech is a little slurred, but they can be having a big stroke before they look really terrible. Again, mimics are actually more common than strokes, and that's why it's really important for us to find the diagnosis quickly, because we don't want to be treating someone for stroke when they in fact are experiencing something else like a demyelinating event or a brain infection. But migraines, seizures with transient deficits afterwards, ingestion, these are some of the other common mimics. What causes strokes in kids? Many things. What doesn't cause strokes in kids? Typically not things like cholesterol, diabetes, some of the things we often think about in adults. In kids, we think a lot about heart disease, congenital heart disease. Vasculopathies are a huge category, or problems in the blood vessels. Some of the most important ones being like dissection or a tear in the blood vessel wall, focal cerebral arteriopathy, which we'll talk about later, moya. We'll also talk about various blood clotting disorders, a variety of genetic conditions, and infection. A couple of important risk factors to know, especially for previously healthy kids, are, kids are more likely to have an arterial ischemic stroke after a recent illness, so that run-of-the-mill cold, and if they have incomplete immunizations. This is, we don't need to memorize the details of this by any means, but this is always our goal when we're trying to think about what causes a stroke in kids, is actually to look at this, what we call the cascade criteria, and say, what category do they fit in, because that helps us understand how to best treat them. And what I want to point out here is that the first 4 of 7 categories have to do with blood vessel problems. So to get into kind of some of our acute treatment options, I want to tell you about 2 more cases that we've cared for here in the last couple of years. The first is a healthy 14-year-old girl who was last known normal at 4:35 p.m. Last known normal, a really important term in the stroke world. It tells us what is the maximum duration we think that a stroke has been going on when we think about our treatment options. And her parents shortly thereafter find her with right-sided weakness and aphasia. They take her to her local hospital, where fortunately they immediately were worried about stroke and got imaging within about an hour of her stroke onset. And she had a head CT that was normal, not a surprise because it was very early. And she had a CTA that had multiple abnormalities in her left-sided circulation and was actually read as concern for vasculitis initially. They calculated her stroke scale at an 8, which is a standardized quick bedside exam that anyone can learn to do, that grades how severe we think stroke symptoms are, with 0 being no deficits, 42 being everything. But generally speaking, we consider, something in the range of 6 or higher to be pretty disabling, something in the range of 12 or higher to be a really severe stroke. On the flip side, we have a case B, which is a 9-year-old girl, and she'd been sick for a few days, kind of some viral symptoms, but was at her neurologic baseline when she went to bed at 9 p.m. That was her last known well. And then the next morning, she had just some altered mental status. She was having trouble talking. She had a fever. And as the day went on, she had this worsening facial droop, prompting her parents to take her to her local emergency room. And we'll come back to both of those cases. But they both highlight one of the most important points, which is time is brain. So our initial goals in when we're worried about stroke in kids are first and foremost have it on the differential so that we can diagnose it. Second is to rule in the diagnosis, knowing that mimics are more common and generally that's being done with imaging. We want to restore blood flow to an area of stroke when appropriate and when possible. We want to protect the areas of the brain that haven't yet had stroke, and we want to prevent more strokes from happening. So when we think about imaging, this is one of our top priorities when we're worried about stroke. And we have multiple modalities available. Often we're starting with CT-CTA because they're fast. A CT head is not sensitive for acute ischemia, especially in the first few hours. But one of the things that we'll look at is something called an aspect score on a CT. And so that's looking at, that's here on the top right. We kind of look for dark spots in these different territories, and it can start to give us an idea of how much kind of permanent damage is done to the brain. And so a score of 10 means we see nothing on that head CT. A score of 0 is all those territories have infarct. MRI is more sensitive. MRI can show us stroke on that DWI sequence within minutes of stroke onset. And vessel imaging is incredibly important no matter which of those modalities we get, because we always want to look for problems in the blood vessels and specifically large vessel occlusion or cutoff of the major arteries of the brain. One of the other things that we're trying to assess with imaging is this concept of the ischemic penumbra. So is there an area of brain that has not yet had a stroke but is at high risk of stroke happening soon? And if so, what can we do to protect that? So we're going to talk now about some of our reperfusion strategies or ways that we try to restore blood flow when a stroke is happening. And there's two numbers to remember, 4.5 hours and 24 hours. So 4.5 hours, this is our window to consider those clot busting medications or IV thrombolysis. These are used off-label in kids. They are not FDA approved. The first kind of acute care trial in kids opened in about 2010, the TIPS trial. This was trying to look at IV thrombolysis in kids. There's actually some thought that using the same weight-based adult dosing that's used in adults is underdosing it in kids due to differences in fibrinolytic activity. Unfortunately, nobody was getting diagnosed fast enough to enroll in this trial. At that time, the treatment window was actually 3 hours. And so this study closed early without actually giving anybody TPA. But from that study became a really important phenomenon, which was the emergence of pediatric stroke centers and pediatric hospitals across the country that started to have stroke pathways of care in place to address that delay in diagnosis. We still don't have great data for thrombolytics, but this is one of the large hospital data studies that showed 270 kids got TPA for arterial ischemic stroke. About 6% of them had any form of intracranial hemorrhage, symptomatic or not, and that's a very similar number to what we know in adults with stroke. But interestingly, it wasn't clear that TPA actually changed their long-term outcomes. So when they adjusted for things like age, size of stroke, location of stroke, 72% of the kids who got TPA did pretty well in the long term, and about 75% who didn't get TPA also did pretty well. The adult world, before we've even figured out TPA for kids, has moved on with their lives, and they now use tenecteplase. This is a medication, it's still a thrombolytic, but has the distinct logistic advantage that it can be given over a single bolus in less than a minute, as opposed to TPA, which we give a 1-minute bolus and a 1-hour infusion. And especially if we're transporting a child, there's a lot of kind of logistic challenges that go into that. We know even less about TNK in kids. There's been some reports that TNK has been used for various clot problems and it's gone okay. The pediatric stroke world accepted that we're going to have to use this sometimes because the vast majority of adult hospitals where many of our kids present are using this medication. And so there's, for the last couple of years, been an ongoing national survey that we participate in. And the first year of data was published showing that 11 kids got TNK. We don't know anything about the efficacy, but none of them had hemorrhage. Only one of those children was really prepubescent, though. So what do we do with that information? We still consider this. We still think it probably helps in certain kids. I personally have seen a teenager we gave TNK to that busted open a carotid clot and restored blood flow to her brain within a couple hours, and she did really well. But we tell families that, this is off-label. There's a lot of unknowns. We know that in adults, if you give, if 1 out of 100 adults with stroke doesn't get TPA, 1 will have hemorrhage versus 6 of them will have hemorrhage if they do get TPA. In kids, we think the risk of hemorrhage is pretty similar. On the flip side, how much does it help? In adults, 38 out of 100 who don't get TPA will still have a good outcome versus 50 if they do get TPA will have a good outcome. And I think that's the area we really don't know for kids. More of them overall are going to do well regardless. Our other main hyperacute therapy that we want to think about is endovascular thrombectomy. This is a minimally invasive procedure done by our neurosurgical colleagues where they can take a catheter up into the brain essentially and pull a clot out via various mechanisms to restore blood flow. This is where we have a bigger window. So 24 hours is generally our window to consider this procedure. This is still relatively new in pediatrics. So 10 years ago, we were starting to get case reports of successfully doing this in kids as it rapidly gained momentum on the adult side. We got a couple of good retrospective studies showing that it was largely successful in a number of kids. This Tiki score mentioned is kind of a grading of how much blood flow is restored. So Tiki 0 is you get no restoration of blood flow with thrombectomy. Tiki 3 is full restoration. So both of these studies showed most children got at least Tiki 2B, which is pretty good, and had relatively minimal complications. Fast forward, I think this is one of the most important papers that has come out in the last 5 years in kids. So this was a study done out of Australia showing comparing 31 children with a large vessel occlusion who underwent thrombectomy compared with 46 who were treated medically alone. And they matched them up based on where the occlusion was, how old they were, which side of the brain it was on. And they showed the number needed to treat to reduce the risk of a poor outcome was 6. That is a similar number to the number of neonates needed to undergo therapeutic hypothermia with concern for HIE, similar number to the number of children who would benefit from early antibiotics to reduce the risk of mortality with sepsis. So that's an incredible number to treat, and why this is the intervention that I lose sleep over if we miss the opportunity versus TPA, TNK, we're not so sure about. Enter a current trial, which is Save Child's Pro. So this is the first prospective study evaluating thrombectomy in children and comparing it to medical management alone in children with large vessel occlusion. We're one of the centers. This is being conducted across 45 centers in 12 countries. And the initial analysis happened after 2020, a data lock in 2023, and did this propensity score matching analysis, largely looking at modified Rankin scores, which for reference, a 0 to 2 on that scale is anywhere from normal to very mild disability where they still function at the level of their peers, and 3 and higher is increasing levels of disability where they need a lot more help. In the long run compared to what you would expect for a child their age. And so this study showed a few interesting things, and this did not, dictate how anyone was cared for at any individual site. It was up to that site to treat children how they thought was appropriate. But generally, we noticed that children who got thrombectomy tended to be a little older. They also tended to have a more severe stroke scale at onset, suggesting maybe a slightly more severe stroke, and yet they did better. So this was congruent with that Australian study showing there is a noticeable shift in children who had a favorable outcome. Interestingly, they also looked at kind of causes of stroke, and the causes of stroke were relatively similar between those two categories. So one might think like, oh, kids with heart disease were more likely to get thrombectomy because we know that's a clot, and it's more on our radar versus children with some other weird vascular pathologies. But the causes of stroke were relatively similar between those two groups. And then there's been multiple sub-analyses out of that study as well. The most important one, I think, is this large core study. So previously, we thought that if a stroke looked so big on head CT or MRI, that the risk of thrombectomy or restoring blood flow was probably too dangerous to consider it. We worry about what's called reperfusion hemorrhage, or you suddenly unblock a pipe and you get too much blood flow in a fragile brain tissue and it bleeds. And so we've generally not taken kids who have larger baseline infarcts, but this study looked at 24 kids who got thrombectomy who did have larger infarcts compared to 16 who were treated medically, and the difference was striking. So 63% of the kids with thrombectomy had a good outcome versus only 25% treated medically alone, and there was actually no difference in hemorrhage between those two groups. This study also showed us a little bit of benefit of IV thrombolysis. They actually took all the thrombectomy patients out and just compared the medical therapy groups and compared those who got TPA versus those who did not. And again, they showed a modest improvement in long-term outcomes in the children who were treated with TPA. They also looked at children with M2 occlusions. When we think about arteries that you can retrieve a clot from, you kind of enter the brain via the carotid, and then you go the M1 segment and then the M2 segment, so getting into smaller arteries. And again, showed even with those smaller, more distal arteries, there was benefit. So big picture, children with large vessel occlusion, by and large, do better if they have successful reperfusion. There's a lot of questions we have left to answer, and a lot of ways that I think we will continue to make this a more accessible and more effective therapy. So when a thrombectomy happens, we're using the same equipment that is used in adults. And so that is not made, that equipment is not made for, tiny children's blood vessels, but it's what we have available to us. There's a lot of things, we rely on the adult stroke studies to kind of pick our treatment windows to some extent. And that's where the 24 hours has come from. But there's some thought that children have better collateral blood flow, and maybe we should consider, their treatment window to be longer. Maybe there is more benefit and less risk beyond that 24 hours. We also wonder if certain populations of children benefit more from this procedure versus are there other children who have higher risks from this procedure. And so I think a lot left to learn. And this is an ongoing study. And even since the first data lock, we've enrolled 25 children from our hospital with large vessel occlusion. So what has that meant for us? We established our first thrombectomy protocol in 2023 here, and we just updated it in the last month or two to really expand the use based on this data that's coming out showing how effective this procedure can be in expanding, the children where we do think it can be effective and maybe slightly less risk than we traditionally thought. And so we're generally considering this for a variety of large vessel occlusions in the head within 24 hours of last known well, if the child is over 12 months of age, if they have a stroke scale of at least 4 to warrant, their deficits are bad enough that we accept some small risks of the procedure, and even if they have a large stroke. So with that, let's go back to our first two cases. So our first case, the 14-year-old who had rapid stroke recognition, that lower left picture is her MRI showing kind of this decent sized left MCA stroke. Again, this was recognized quickly. Our team was contacted. She was quickly transferred to Primary Children's Hospital for further care. Our 9-year-old patient, case B, this is her MRI a little later in her course. And so what I want to point out here is that they both had decent sized left MCA strokes, and yet their courses are going to look really different. So our first case, she actually got TPA. She was well within that window. Her stroke scale was actually a 10 at that point, which is pretty darn disabling. And we were able to mobilize our resources to arrange for endovascular thrombectomy when she arrived to us. She had 2 areas of clot. Initially, there was this concern for vasculitis, but our radiology team here looked and thought actually there's 2 clots in her head. And after TPA, that first clot in the anterior cerebral artery resolved spontaneously. And then she had thrombectomy that went after the middle cerebral artery clot. Interestingly, within a few minutes of that, another picture was shot while she was still in the angio suite and showed a more proximal occlusion of her middle cerebral artery. So she had a distal occlusion that was opened up, but now all of a sudden she shut down even earlier. Fortunately, another thrombectomy was performed and blood flow was restored. And postoperatively, she had this MR angiogram that shows pretty good blood flow through that middle cerebral artery, and her stroke was stable. The next day, she went from a stroke scale of 10 to 1, which is a huge improvement. She had mild difficulty finding her words. The day after that, she actually had no appreciable deficits. Unfortunately, later in the day, had abrupt worsening of her symptoms and had imaging that suddenly showed severe narrowing and irregularity through her arteries and a very slightly bigger stroke. She also had vessel wall imaging shown here on the right, which showed avid enhancement, suggesting inflammation through the blood vessels, even beyond the areas where she had gotten thrombectomy. We diagnosed her with focal cerebral arteriopathy, which is an inflammatory disorder, treated her with steroids, put her on an extra antiplatelet medication, and gave her time. We know that in kids with FCA, they get this pretty quick and dramatic narrowing of their blood vessels and can get very what we call flow dependent, where even things like the challenge of gravity or slightly lower volume status can be the thing that tips them over the edge to having more stroke. And so just by keeping her relatively flat, keeping her hydrated, keeping her blood pressure on the high side, we were able to wait that out over a couple of weeks, and she had no further stroke and discharged home without the need for rehab, actually, with very mild word finding difficulties. She did get outpatient speech therapy. After 90 days, she was completely at her baseline, and today she's an honors student in high school, despite that stroke. So our second case, on the other hand, the 9-year-old girl, she was seen in her local ED. She had multiple tests that were done. She was eventually transferred to Primary Children's, where the concern for stroke was raised. She underwent imaging, was found to have a tandem occlusion. So she had an occlusion of her carotid artery and her middle cerebral artery. But unfortunately, by the time that was diagnosed, she was well over 24 hours from her last known well. And we thought the risks of something like thrombectomy were too high to provide benefit. She had a stroke scale of 12, was admitted to the PICU, treated initially with aspirin fluids, monitoring for seizures to minimize any metabolic stress on her injured brain, and monitored with our neurosurgical colleagues for consideration of hemicraniectomy given a large stroke. She did have worsening of her symptoms, though then stabilized. Unfortunately, despite undergoing inpatient rehab and good outpatient therapies, she has really continued to struggle more than a year out. She's struggled to be consistently in school. She has really bad anxiety. She continues to have some aphasia. Though she's ambulatory, she struggles a lot with walking and fatigue. And so 2 similar strokes, but the time to diagnosis made a huge difference in how each of those girls did. A brief note about decompressive hemicraniectomy. Though this isn't a reperfusion therapy, it's still something we think about very carefully in the first day or 2 after stroke. So this really increases the survival for kids with large MCA or posterior fossa strokes. And there's some suggestion that doing it in the first couple of days probably improves outcome, though there may still be benefit beyond that. Most kids who need a hemicraniectomy are going to have long-term deficits, but unlike adults who have a stroke that big, most kids are going to regain the ability to walk and talk, even if they still have some deficits. The indications are, there's not one hard and fast formula that we follow for who needs this. We use a combination of clinical and radiographic features to consider this intervention. So with that, we're going to shift into, how do we put that together in our hospital? And I'm excited to tell you that we have a new inpatient pediatric code stroke that is rolling out next week, finally. This has been a huge collaborative effort through, multiple divisions within our faculty and groups in the hospital. But, and I should mention, our emergency room colleagues have for years actually had a protocol very similar in place to improve the detection and initial treatment of children with stroke in the ER. But in the hospital, this is our new pathway that is rolling out. This mentions the symptoms of stroke, the genetic consideration, children who are at particular risk, so children with trisomy 21, other genetic things, thrombophilia, those types of disorders. You call 33333 to activate it. I want to point out this large, long box on the right. That is all the people who are activated and have to respond, because this is a team sport and every minute matters. And so there's a lot of people who will be responding to these to help make sure that we can rapidly diagnose and effectively treat children. The initial steps are largely assessing the child, determining what their last known well is, to understand what they might be eligible for in terms of treatments, doing a stroke scale, getting some labs, and getting imaging. As we talked about, we must rule in the diagnosis, given that there's a very good chance that they're really having a different neurologic problem. If they're within 4.5 hours of last known well and we confirm an arterial ischemic stroke, we're going to consider one of those thrombolytic medications. We've decided to use tenecteplase if they're roughly adult sized, which we're defining as 12 years old and 40 kilograms. And for our younger kids, we're still using alteplase. We have this checklist to make sure that there's not a reason not to give thrombolytic in that time frame, and this largely goes through things that we know are high risk of hemorrhage. We also incorporated our thrombectomy protocol. Again, to me, this is the big do not miss intervention for children with large vessel occlusion, and we've already reviewed those indications. But again, just want to highlight that there's still a lot of people we have to mobilize and resources to activate to make this happen in a timely fashion. What about the children not at Primary Children's Hospital, though? I'm getting back to my not villain origin story, just my personal origin story, I guess. But implementing pediatric telestroke, that's something that we've been able to do over the last year to help our kids who are not starting their journey here at Primary Children's. So starting in September 2024 and kind of extending into January of 2025, we rolled out a pediatric telestroke service in Utah and Idaho at 24 Intermountain hospitals, as well as to support our Miller campus at times. And just the process of rolling that out was really cool in a number of ways. First is, I want to give a shout out and express my appreciation to my neurology colleagues, who most of whom do not share my adrenaline rush when I get a code stroke page, and yet have been very willing partners in staffing this telestroke service. And then, another thing is we met with providers at all of these different hospitals. So ER providers, pediatricians admitting to those hospitals, nurses, stroke educators, stroke coordinators. And it was striking to me how many times we told them about our telestroke service and got the response, "I didn't know kids actually have strokes," followed by this look of fear in their eyes. But that's what we want to address with having this, this program in place, is we want to provide a service that empowers clinicians to put stroke on the differential, even in children, to rapidly access our team here, and to work together through roughly the same protocol as if they were in our own hospital walls, to rapidly make the diagnosis and provide the most effective treatment when every minute matters. And so this looks quite similar to that inpatient algorithm that I just showed you. And essentially, the goal is to get imaging and labs to establish some of those baseline information features that are important in making treatment decisions. During business hours, we promise to answer the phone within 5 minutes and be on camera within 15 minutes to help assess the patient, talk to the family. After hours, we're currently offering phone advice only, though still in a timely fashion. And really, I think having this pathway in place in a variety of hospitals, we hope will continue to help address the delay in diagnosis. Um, we use the same kind of criteria when considering thrombolytic, and we can do that. These hospitals are equipped with the same thrombolytic medication, so we can do that even before they get to us. And then we have just kind of a transfer algorithm. In addition to recognizing children with stroke and getting them here quickly, especially if we need to perform a thrombectomy, we also want to capture the children who aren't experiencing stroke or who are experiencing a different neurologic problem that can be treated close to home, who may not need to come to us. So we're only a year in to this rollout, and in the first year, we did 21 telestroke consultations across 13 sites, and 5 of those ended up being acute stroke and vascular diagnoses, so about 24%. And so considering we expect about a 30-70 split, I counted that as a win, because one of the concerns with rolling this out is this just going to be a way to rapidly get a neurologist, or are we really going to be selecting kids with strokes? But I think we did a pretty decent. And when I say we, I mean the community hospitals, not me personally. The median age of children who got a telestroke consultation was 13. Only one child actually was under the age of 8. 19 of them got acute neuroimaging, including 15 getting vessel imaging and 14 with MRI. 4 of the children ended up being admitted here to our PICU, and one of those children, due to the kind of the telestroke consultation, we were able to arrange an emergent diagnostic angiogram on her arrival to help guide her initial treatment. The mimics were about what we expected: a lot of migraines, a lot of seizure-related deficits, child with acute demyelinating disease. I think we're just at the start of this, and I'm really excited to see, how many more children we can reach and how we can continue to chip away at that big problem of delay in diagnosis and decreased awareness of children having strokes. So one thing is, many strokes happen outside of those business hours where we have somebody on camera. So thanks to support from the Primary Children's Foundation, we're going to be able to expand our hours for camera consultation starting next month out to 10 p.m. And then in July, we'll be going full 24/7 with that coverage. We're looking to add additional sites to expand our reach, and as we expect our volume to grow, we also plan to have regular debriefing, ongoing education, figure out why we're not reaching the young kids as much as we expect, things like that. So switching gears from there, this is probably overhyping this section, but this is what I'll call precision pediatric stroke care. And what I want to talk about is why it matters, what's causing stroke and how we use that to determine how to care for them. So arteriopathy, or trouble in blood vessels, accounts for over half of arterial ischemic stroke in kids. And not only does it cause strokes, it causes recurrent strokes. So some of the most common things we think about are FCA, which we briefly spoke about, moya, dissection or tear in the blood vessel wall, genetic syndromes, and the list goes on. Again, this is those criteria where from the beginning, we're always trying to figure out where can we fit the stroke etiology, because it really helps guide our treatment steps. So FCA, that's what our patient A had, the one who did really well and is now an honor student in high school. This has gone by many names over the years, but this is the most common arteriopathy in a previously healthy school-age child. There is also a geographic predominance, and this occurs most commonly in the western region of the United States. It's mostly in kids, rarely occurs in young adults. The thought is that it's like a post-infectious or a viral reactivation phenomenon, and so it commonly affects the top of the carotid artery, the middle cerebral and anterior cerebral arteries in the area that the trigeminal ganglion innervates, and so there's a thought that you get viral activation that causes an inflammatory cascade and causes this progressive narrowing of vessels in that region. A lot of kids will have some sort of vessel thing apparent when they present with this, such as it'll be clotted in the area that it's inflamed, or it'll be narrow, though some kids will present with a stroke before you can actually see anything on imaging. And so it's always important for us to keep this in mind. This disease has actually been identified as the top research priority in the international pediatric stroke community. And so this led to the Pasta trial, which was done in Europe in recent years. And what they were doing was comparing treating children with aspirin alone versus aspirin and steroids, understanding this is probably an inflammatory process. And what they showed was that the children who received aspirin had a better long-term outcome. That's the pediatric stroke outcome measure. And they had increased likelihood of their vessel returning to a normal size. We're part of the current only NIH acute funded stroke trial, which is the FOCUS trial. This is the focal cerebral arteriopathy and steroids trial. And so this is answering a different question. This is trying to answer, do you start treating everyone with steroids on day one when they might have FCA? Or do you wait until you're sure that it's FCA? So the way we definitively diagnose this is to see progressive narrowing of those arteries over a matter of days after stroke presentation. And so do you give them steroids when it's high on your differential day one, or do you wait to know that that's the right diagnosis? And can you prevent, by giving steroids earlier? We know it helps in the long run, but can you prevent the risk of kind of early recurrent stroke or how bad the vessels are going to get? Because of how much FCA we see here, we're currently the highest enrolling site in this trial, and it's about a third enrolled. And so I think we're going to have a lot of data in the next 5 or so years out of this trial. It's also collecting some interesting data like biomarkers out of biologic samples that might show us more about what actually causes this, and can we be even more precise in our treatment besides steroids. To highlight another case, this is a teenager who also had FCA. He actually had transient difficulty opening a tuna can when he was trying to make a tuna sandwich for breakfast. And his mom noticed a brief facial droop, took him to his hospital. And he was back to normal by then, but they got an MRI that confirmed he had a stroke on the right side. His vessels were totally normal. They still flew him down to us to take care of. He continued to actually be at his baseline. We did a workup, didn't find a cause, and we said, this still could be FCA, so we better not send you home just because you're, back to normal. And so we watched him in the hospital for 5 days, repeated the imaging, and sure enough, he lost his flow through the middle cerebral artery. But he did not have a bigger stroke. We treated him with steroids, we had him on aspirin, and we had been really careful through that time. And not let him get up and run around, knowing that if he had FCA, he could be developing worsening narrowing and suddenly have stroke extension. On the flip side, this is another teenager who presented initially to us. Our emergency room immediately recognized that she had stroke symptoms, got imaging. She was found to have this narrowing at the end of her M1 segment and occlusion. She got TPA and thrombectomy and had this decent-sized stroke here in the middle. Unfortunately, within a couple hours of that procedure, she had worsening, and her entire middle cerebral artery had cut off really from where it takes off at the carotid. And further investigation confirmed she had FCA. And so this highlights one of the challenges, which is sometimes we're not sure, is that a clot? Is that an inflamed vessel? And if you stick a catheter up there, are you causing more harm than good because you've just set off this very reactive cascade? And she unfortunately ended up with a much larger stroke. So what do we do with that? We keep in mind that it's very common here, and so we always think about FCA when we have a unilateral stroke and we don't know the cause. We consider sitting on those kids for a few days before we really liberalize getting them out of bed and running around, knowing that at any moment they could get more.
Code blue, main building, northeast, 3047. Code blue, main building, northeast from 3047. Code blue, main building, northeast, 3047.
So we sit on these kids. We don't let them run around. We know that they could be developing narrowed blood vessels, and we repeat their imaging after a few days. We still consider thrombectomy, even if we think it might be FCA. The Save Child's Pro study showed that even in children with FCA, there was still benefit, but our surgeons think a little bit differently about maybe just trying to use suction to suck out a clot as opposed to sticking a stent retriever through a potentially inflamed vessel. Another important disease to think about when we're thinking about what acute therapies might we offer a child with ischemic stroke is moyamoya. This is a progressive steno-occlusive disease, most commonly where over time you get narrowing and eventually occlusion of the top of the carotid arteries, not due to clot, the vessels themselves are shutting down. And this is more common in a variety of genetic syndromes listed there. But because this is a chronic, progressively occlusive disease, the treatment's a little bit different. So we generally don't want to give these kids thrombolytics. They've developed these tiny little cloud-like collaterals. Moya means puff of smoke in Japanese, which you get on this appearance on imaging. And those are at risk of rupture. And so we think that thrombolytics are higher risk in this group. It's also, we don't think there's like a clot to bust through necessarily. Similarly, we generally don't think about thrombectomy because this is a very chronic process that has happened. But what we know is that, these kids are relying on these tiny little collateral vessels, and they can, again, be very flow dependent. And so things like aspirin, keeping them flat, giving them lots of IV fluids, keeping their blood pressure high, that helps us give them kind of more blood flow in real time. And in the long run, our neurosurgical colleagues, especially Dr. Ravindra, have procedures they can do to augment blood flow, kind of implanting blood vessels on the surface of the brain or other techniques to give them extra blood flow from the outside that grows in over time to reduce their long-term stroke risk. Face syndrome, I always like to mention because this is often diagnosed in pediatrics and dermatology. This is, a combination of findings often set off by noticing an enlarging infantile facial hemangioma in a high-risk distribution, but is associated with arterial anomalies, especially in the head and neck, heart problems, eye and endocrine issues. And one of the first questions that comes up is, can you treat these kids with a beta blocker to treat their hemangioma? And because we know they have a high risk of having arterial problems in their heads, to answer that question from a stroke standpoint, what is the risk of a stroke in these kids? We need to assess their blood vessels, and it all comes down to the circle of Willis. And understanding, do they have an entirely absent artery? If they do they have multiple ways to supply blood flow to that brain? Is their whole brain dependent on one carotid artery? Do they have an area that's severely narrow? And so we look at a variety of factors to understand, do we think that they're, really, really high risk where even a little bit of blood pressure drop from a beta blocker is a concern? We also follow these kids long-term because they can have progressive ballooning or aneurysmal dilation of their vessels, and some of them can even develop moya moya. So kind of to almost wrap things up, I wanted to mention genetic testing. I think when I was, doing adult stroke training, every time an adult had a stroke and we didn't know the cause, they got an implantable loop recorder, or depending on insurance, a Holter monitor, to look for AFib as a cause of cryptogenic stroke. In kids, I think genetic testing is actually kind of our roughly equivalent thing. I think that we have so much more to learn. We're really just kind of touching the surface at this point. But generally, we're considering sending broad genetic testing for any child where we don't know the cause of stroke, to look for more kind of broad causes that helps us care for them in the long run. And so unless, they have something really obvious like endocarditis or, a clear traumatic cause of dissection, this is something that we're considering. And to kind of highlight how that has changed our management for a couple of patients, this is a patient who came to us. She was 10, jumping on the trampoline, developed a headache, wasn't doing anything crazy like a backflip or anything. And then over the next day, worsening headache and progressive right-sided weakness, was found to have this stroke on the top left here. And her vessel imaging was suggestive of potentially a large carotid dissection with near absent flow through much of the upper part of her carotid artery. And thrombus. And so we started her on anticoagulation. Unfortunately, she came back just a couple months later with a new stroke, shown here in the middle. And at that point, what we saw was she had, this cutoff at the top of her carotid artery. And we thought it was, kind of odd, if she had a dissection, that it was that far into her head. She got an angiogram. And ultimately, we did genetic testing and found something that surprised me, which was a COL4A1 mutation. That's something we more commonly think of as a cause of significant in utero strokes in babies. And so I've not seen a previously healthy 10-year-old who was found to have this condition, but was really important because anticoagulation is actually relatively contraindicated in children with COL4A1 due to the risk of hemorrhage. And so we switched her to aspirin. This also isn't, we wondered for a moment, does she actually have early moya moya? Not known to be associated with her gene, but time will tell, I think. But also gave us clues that we should be doing other things like looking for arrhythmia, and we know there's, other organ systems that can be involved with COL4A1. This is another child. This was a toddler who came to us after he had some transient neurologic symptoms after falling off a couch. And he was found to have this very unusual arteriopathy where his middle cerebral artery on the left was replaced by this little tingle of vessels. Didn't quite look like moya moya, though we wondered. He also had an interesting history of some delays and hemangiomas, and so we sent genetic testing, and he was found to have a gene that was associated with hemangiomas and non-progressive kind of congenital vascular anomalies. Which makes us think maybe this is less likely to be a progressive moya moya type picture. Don't worry, we'll continue to follow him and make sure that we're watching him for his stroke risk. But besides those, where we see genetic testing helps us find an answer, but also better understand maybe what the long-term risks are. Genetic testing sometimes helps us end the diagnostic odyssey and find closure for children after stroke, helps us understand the need for screening even outside of the head and neck, can help us guide if they should have specific activity restrictions. So if they're found to have a disease that weakens their blood vessel walls, do we want to be more proactive about saying no trampolines, no roller coasters? Helps us understand, are they actually at risk for a more progressive vasculopathy over time like moya moya? And I think one of the most exciting things, and this is going to change a lot in the coming years, is I think there's more and more kind of targeted medical therapeutics that can be used to mitigate stroke risk in certain genetic vascular diseases. My last thing I wanted to go through is just, we talked a lot about the acute care of children with stroke, but what about after the hospital? The medical care after the hospital is a few things. So we want to make sure we're addressing secondary stroke prevention. So how do we prevent more strokes? And that's individualized depending on the cause of stroke, the size of stroke, how old the child is, things like that. Sometimes we think about those activity restrictions like we talked about. If children are highly relying on, one particular vessel to supply a lot of their brain, we might have an earlier look and be more aggressive about things like cholesterol and blood pressure. We talk about immunizations. We know that there's actually a little bit of less risk of arterial ischemic stroke in children who receive their routine immunizations, including the flu shot. And then we want to watch them for evolving deficits. There's kind of a phrase, children often grow into their deficits or their disability over time. A year or two out from stroke, we may not understand what challenges they're really going to face 10 years from now. And so ongoing reevaluation of their developmental and academic needs, low threshold for neuropsych testing or school evaluation, screening for ADHD. Up to half of kids with arterial ischemic stroke are going to have ADHD, and treating that can drastically improve their quality of life and school performance. Assessing the child and their family for mental health and stress. Those are major issues after stroke in kids. Stroke shouldn't happen to kids, right? And they're under-recognized. Continuing to address, rehab and school support. Those matter as much as medical care in the long run. And then screening for other things that affect their quality of life, like seizures and headaches. So with that, I can't possibly acknowledge everyone here who's important for stroke care. It really is a team effort across all divisions, across this hospital, but these are some key members of our team. I'll let that go.
Code blue, adequate response, 3 northeast, 347. Code blue, adequate response, 3047. Code blue, adequate response, northeast, 3047.
So you've heard a little bit about some of the things that we're already doing at Primary Children's, but roughly breaking it down, we're always working on more protocols. These are still rare events that many people are only going to see, every few years. And so we want to put protocols in place as much as possible to not always be reinventing the wheel and be as well oiled of a machine as possible. We're working towards having our first kind of pediatric stroke educational retreat. We've recently established a multidisciplinary clinic to follow up kids with strokes. We have our first pediatric stroke fellow this year, McKenna Coletti. We continue to have a partnership with the adult vascular neurology division and continue to learn a great deal from them about the care, as they care for adults with strokes. And then we have numerous kind of research things that we're involved with and are really excited to be involved with. I think families of children with strokes, it's very meaningful to them to be able to contribute to research, because having your child have a stroke feels really unfair, and it often, gives this feeling of at least we can maybe help other people in the future, and that's really our goal. I'm not going to actually quiz you, but this is a review of those terms that we used of how to talk like a stroke neurologist. So in conclusion, first and foremost, time is brain. Stroke is an important cause of death and disability in children long term, and decreased awareness until delayed a diagnosis remains one of the biggest challenges we have in acutely caring for children with stroke and reducing their long-term disability. And so if there's one thing that I hope that everyone takes away, it's don't be afraid to ask the question, could this child be having a stroke? And tell your friends, kids have strokes too, raise awareness. We're using Pediatric telestroke to increase the awareness across our region and hopefully mitigate this to some extent. Rest assured that, even if a child has symptoms of stroke, it's actually still more likely that they're having a stroke mimic. And honestly, if we diagnose a stroke every time we activate or raise that alarm, then we aren't raising that alarm enough. We do have some reperfusion therapies that we're getting increasing, we have increasing evidence for, especially thrombectomy. Only takes 6 kids to treat to really make a huge difference in how they do in the long run. We want to think carefully about arteriopathy, because that's very common in children, and it affects, what therapies are helpful and what the risks of different therapies are in the acute period. And I think we're going to continue to learn a lot over the coming years about the genetics of stroke. So I'll end there. This is our team walking at the Raising Stroke Awareness at the American Heart Association and Stroke Walk. Thank you.
Thank you so much for teaching us, and that credit code is 52518. It sounds like the adult hospitals, they see stroke all the time, and they learn how it presents in kids. And we see kids all the time, but we're learning about stroke. And we're getting that brain fusion together, but figuring it all out. Thanks so much. I'm more aware now than before. I really appreciate it. And what questions do we have?
I had a question. Just with the focus trial, if you're starting steroids like at the start, does that ultimately affect like their repeat imaging and their diagnosis to know that it's actually FCA?
To be determined. Yeah, we've enrolled. I'm probably not exactly allowed to say what has happened to the patients we've enrolled. We have enrolled kids where it's on the differential and has probably ended up not being the diagnosis who have still gotten steroids. But I think one of the questions we don't know is like, are you actually masking it entirely? Are you going to know if it was a diagnosis or did you prevent the progression entirely? And so, some of the other things they're looking at is it a problem to treat children, a few children with steroids who maybe didn't have the disease? Are there any complications of that? But I think we don't know, and it's one of the questions we want to answer. Yeah.
That you're getting off the ground also sounds awesome. You gave the numbers of, how many referrals, et cetera. Do you have a sense of like how many more children are out there that were missed thus far and that we could like still capture?
I don't have a formal number. We're actually, going to be setting up a dashboard to track this and better answer that question because that's going to be really important for how can we optimize it. I think we're missing, I've noticed we've missed a number of young kids in particular. Yeah, especially more that like the toddlers, we're missing them, and sometimes it's because their symptoms can be vague. They're not acting right. It's hard to get them to do the perfect stroke scale. It's hard to get them to walk when they don't want to, things like that. But it's certainly going to be one of the important things as our volume grows to really systematically track who we're also not seeing via that. Yeah.
Great job, Lisa. IV thrombolysis is not a contraindication to endovascular therapy, right?
Correct. Yes.
And how long do you have to wait after?
You don't actually. Yeah, really good question. Thrombectomy, of course, is a little bit invasive. You're doing an arterial puncture, but actually we'll consider doing it even if TPA is still running just because of risk benefit of time as brain, restore perfusion every way possible versus the risk of bleeding at the site of puncture. So we don't wait any time at all. It is nice, though, for our ones who can get tenecteplase because it's not still actively running as we enter the IR suite.
All right. Thanks again. Take care,
Thank you.
everybody.